Good evening, friends. Welcome to this Tuesday evening academic sessions of clinical interest and curiosity. And we bring this academic activities and events through both IDCCM Hyderabad chapter and Yashoda Group of Hospitals. And today we have an interesting topic of many of our clinicians and students concern, that is ventilator associated lung injury or induced lung injury, and understanding stress, strain, and power. And now we are talking about the mechanical power and its interpretation. So it happens to us that Dr. E Raja Gopalan has been a seasoned speaker and a star campaigner in this part of the world in the academics of critical care medicine. We all been grown up as a clinicians in the Department of Critical Care Medicine, looking up to him, inspiring by him. And he is teacher for many of us, including many consultants in the field of critical care medicine. So we are privileged and honored to have Dr. E Raja Gopalan sir again on the platform to speak about ventilator-induced lung injury and mechanical power and its interpretation. Sir, we welcome you on board, and it is our honor to have you here, sir.
Thank you again, Venkat. Thanks for inviting me every time. Okay. I'm sorry.
Yes, sir. Please, over to you, sir.
Yeah, I'm sorry. Did I jump in a little early?
Please switch on your camera, sir.
For my camera. Where do I switch it on? Hang on just a second. Okay. Is that?
Yes, sir. Good to go.
Okay. All right. Thanks again for inviting me to give a talk.
Sir, just a little bit of camera, sir. Your half, the face is not been covered.
Is it okay?
A little bit, sir, away or...
I'm sorry, I'm not able to see myself on the camera.
Okay, sir. Please go ahead. I think you
are... Don't worry about the face.
Yeah, head part is getting focused. Please.
The head. Okay. Is it better now? Okay. All right. Apologize for a few of these interruptions, and I'm sorry that I'm not able to see myself on the camera, so I'm not able to say very clearly what is going on. Okay. But I hope that this lecture, I'm sorry, I'm getting something in the way.
We can see you and both your slides and yourself, sir, very clearly.
Okay. All right. Okay. So I was invited to speak mainly on the issue related to power as far as the lung injury is concerned. And I think that this would be a little bit of a complex lecture in the sense that a lot of what I'm going to deal with is physiology and physics. And so you'd have to be a little patient with me if you're going to listen to what I'm going to say. But I'm pretty certain at the end of it, you will have a reasonable understanding of the idea or the concept of power. And I probably will end this lecture with saying how we can apply it and what the limitations are in terms of the application when we in the current day as we see it. Okay, as we clearly know, and I think it's not a very big problem. One of the biggest problems that we face when we're ventilating a patient with acute lung injury or ARDS for that matter is the amount of iatrogenic injury that we can create in the process. And what I'm going to show you during this discussion is to make us understand how this iatrogenic injury occurs, basically explaining the physics behind it, and trying to see how we can limit this injury, because it will go a long way in terms of improving our outcomes as far as the ARDS is concerned. Okay, I think again, none of us have any doubt about the fact that tidal volume is a very important component to ventilatory support. And the lower the tidal volume, the less likely you're going to create injury. And the benefits in terms of survival and in terms of hospital discharge are very well illustrated in the famous ARDS net trial. Okay, but besides the ARDS net trial, if you really look at cohorts of patients with normal lungs, the reduction in tidal volume is very clearly associated with an improvement in outcome. So in general, I think none of us will have any kind of a doubt about the fact that low tidal volumes are very important to minimize the injury. Likewise, we also probably will broadly agree that the airway pressure is also equally relevant. As you see over here in the ARDS net studies, not only is a reduction in the tidal volume from 12 to 6 an important way of reducing mortality, you can also see the broader trend that as the pressure quartiles or the plateau pressure is progressively declining, there is also a decline in the mortality. Or in other words, it is not just the tidal volume that matters, it is also the pressure that matters. And this interaction between pressure and volume is probably something that all of us understand is going to be the predominant mechanism by which you can create lung injury. So to understand this pressure-volume relationship, it is very typical for us to use a simple concept. We like to believe that the lung is effectively an elastic structure. And this is reasonably justified when you look at the interstices of the lung parenchyma. There are basically centripetally running elastin and collagen fibers. And these elastin and collagen fibers effectively function like elastic structures. Okay. And to view the lung as an elastic structure implies that if you transfer energy to this elastic structure, the greater the amount of deformation that you create in this elastic structure, like pulling a rubber band apart, the more likely you're going to create injury too. And it is very important for us to understand this relationship between the stretch of the fiber and the deformation that we create in the fiber. Okay, and this is explained usually in terms of simple laws of physics related to elasticity. Here, what I'm demonstrating on this graph is if we stretch a fiber by applying a specific pressure across the fiber, like I'm showing you with the two hands up there, you're creating a stress or a force to cause a deformation of the rubber band or the fiber. Now, as you stretch that fiber, you're also lengthening the fiber, or you're creating a certain amount of deformation of the fiber also at the same time. And within the elastic range, as we would call it, the relationship between these two parameters, what we call the change in pressure, which is also known as a stress, and the change in length or the change in the deformation, also known as a strain, have a linear kind of relationship. When they exceed this elastic limit, there is a likelihood that this relationship can be altered, and you get to a point known as the yield point, at which you effectively will cause a rupture or a permanent deformity or a rupture of the elastic structure. And this is the region at which you potentially can be creating damage to the elastic structure. Within this range, as you increase the stress, you're likely to increase the strain, and as you reduce it, it's going to come back again towards normal. The relationship between the stress and the strain is usually expressed as a parameter K that is also known as the Young's modulus. Okay, I just want you to just remember these basic structures. Okay, so with the lung being viewed as an elastic structure, I think we need to look at it a little bit more realistically, because this is not just a rubber band. Okay, so we need to understand how we will express lung stress. Lung stress is usually the transpulmonary pressure that you generate during inspiration. And this, remember, is not just the airway pressure that matters, it is also the pleural pressure. And the difference between the airway and pleural pressure, ideally measured by an esophageal pressure, would be the transpulmonary pressure, which is the equivalent of the stress. So the stress is the transpulmonary pressure. Remember that the pressure airway and the pressure lung will be equivalent only under passive states, like in controlled ventilation, but we don't necessarily usually measure the pleural pressures, okay? And as a consequence, we may have a little bit of an inaccuracy in the determination of our lung stress in a clinical kind of setting. Additionally, the lung strain is the change in the deformation or the lengthening of the alveolar structures. And here, basically, the way we look at it is as a change that you induce from the basal resting state of the lung, which is from the FRC, the addition of a tidal volume creates a certain amount of strain. And usually this strain is expressed as the change in the volume. And this is a dimensionless kind of a parameter that is expressed as a parameter of the basal volume. So for instance, if I have a tidal volume that is equal to the FRC, okay, I will have a strain of 1 when I have a tidal volume that added to the FRC, that will be effectively 2 times the FRC will be the lung volume when I have a strain of 1. When I have a strain of 2, it will be about 3 times the FRC. I think we'll get to this a little bit later again. So effectively, what we are looking at is a stress on the lung, which is expressed as a transalveolar pressure, and a strain on the lung that is expressed as the ratio between the tidal volume and the resting volume, which is the FRC. Okay. So with this as the understanding, if I take a pig model, okay, and you look at the lung characteristics, it's going to behave like an elastic structure, where with the increasing amount of stress on one axis, the strain is also going to change. Okay. And what we talk about is a strain of 1, which is the tidal volume equivalent to the FRC, is going to be this parameter. And if you look at that, we will look at the Young's modulus expressed as in the form of what is called a specific lung elastance. It doesn't matter. We don't need to know these parameters, but broadly we can express that the stress-strain relationships is very species specific. So what you see in a pig will give you a certain parameter. What you see in a human will be distinctly different. Okay, and very often these relationships are extrapolated from animal models to human models, and it is based on a presumption that these relationships can be easily extrapolatable. Okay, so with this as the broad kind of basis, I think we need to understand that as we stretch the lung and as we create a greater amount of stress and strain on the lung, we can potentially cause biological changes that are quite important. The extracellular matrix can be hurt by this process of the stretch, and the development of edema is pretty well known to occur. The more you stress or strain the lung, the more likely you're going to create a certain amount of damage. This damage can also be further, through a process of mechanotransduction, initiate an inflammatory process that can cause a further worsening of the lung injury, and frankly can create the ventilator-induced lung injury that we always talk about. Now, what is the level to which we must be changing the stress and strain for you to create injury is shown by these pig models again. As you can see, the patients who develop lung edema are marked in blue. The animals that didn't develop lung edema are marked in white. Okay, and what you see very clearly is the amount of strain that is developed, or the change or the deformity in the lung volume is a very strong predictor of the development of lung injury. The more you strain it, the more likely you will create a lung injury. As you see over here, a cutoff value of around 1.5 or so is probably what is associated with a development of a lung injury. 1.5, closer to 2, I would say. So again, if I was to look at the same model again and look at the stress-strain relationships, through the lung period where you're developing an increasing strain reaching 2, which is effectively 3 times the functional residual capacity or the equivalent of your total lung capacity, you probably do not create any injury. And after that, you seem to have an extrapolation of, a rapid exponentiation of the amount of injury that you can be creating. Now, this is something that we need to be very careful and extrapolate to the humans. It almost seems to suggest that if we were to take the lung as a simple elastic structure that is following the simple rules of stress and strain effectively, that you will create lung injury not at the kind of FRC that you're basically talking about. So in the pig model, if we are creating an injury at a level that is roughly equivalent to the total capacity in the pig model, 900 ml, in the human, that has to be extrapolated to almost 6 liters. Or in other words, if we were to believe that lung injury is caused by a simple elastic principle, we need to expand our lung to total lung capacity, or almost 6 liters, for you to create injury. Now, this sounds frankly impossible. You'd always say, what are you saying? Do you really need to stretch your lung to a total lung capacity? That is, you need to give a tidal volume that is so large that you need to, that will create injury? And the answer to that will be something that will leave us all worried and say, how can that be true? We know for a fact that we can create lung injury with stretches that are far less than what this model seems to suggest. Let me just stop over here and clearly express myself all over again. So the way in which we believe lung injury, the lung injury model that is ideal, would be the elastic structure, primarily because the interstices of the lung has elastin and collagen fibers that behave like an elastic structure. So in an elastic structure, the more you stretch it, the more stress you create, the more strain you create. And in proportion to the rising stress and strain, you're likely to create injury. What we see in the animal models is to create an injury of significance, you need to create a massive rise in this strain, or the tidal volume should raise your lung volume to almost 3 times the functional residual capacity, or greater than the total lung capacity for you to create an injury. And that sounds a little dubious. So we have to have a mechanism by which this injury can be created by far less stretch. And this idea is basically what we would call as stress raisers. I hope I will be able to explain this concept a little clearly. Okay. Now, very typically, when we're talking about these kinds of lung injuries, we like to believe that the lung is a uniform structure and that all alveoli are open and intercommunicating with each other, and with no differences in the pressures between one alveolus and the other. Or in other words, the interalveolar pressure is net interalveolar pressure is 0. So if I was to exert a transpulmonary pressure, okay, of a specific value, it will be uniformly translated to every single alveolus. And as a consequence, the stretch will be more or less uniform. But this is not at all true. The average lung, even under normal condition, is going to be characterized by areas of alveoli that are significantly deaerated, primarily because there may be atelectatic segments, particularly in the dependent parts of the lungs. There can be deaeration related to obstruction of the peripheral bronchioles, effectively from the accumulation of secretions. There can be dynamic changes, which can cause non-uniform ventilation, and therefore there can be differences in the alveolar sizes. There can be stiff bronchi, which can cause pressure on the alveoli, and vascular structures, which can also cause pressures on the alveoli. And this will result in a completely heterogeneous kind of a lung. And under conditions of pathology, actually like in ARDS, this heterogeneity can be further exaggerated. And what we saw as a model of the lung in which there is a uniform expansion of all the alveolus will not be seen even under normal conditions, and particularly under conditions of pathology, there will be absolutely no way that the lung will look uniform. Now, this creates a very significant change in the stress-strain relationships. So if I was to look at the normal lung under these structures, the transalveolar pressures are going to be uniform. And in fact, there is going to be no difference between the pressures between each alveoli and its adjacent alveoli that you will see around it. On the other hand, if you have a non-uniform structure, there is going to be a deformation of the collapsed alveolus, okay? And the opening pressure of this deaerated alveolus is going to be dependent on the pressures that are, the distending pressures of the alveoli that are surrounding it. And this distending pressures of the alveoli that are surrounding it are going to be changed very significantly in a non-uniform structure, primarily because these alveoli are likely to be anchored by by the fibroskeletal structure of the lung. And as a consequence, the stresses on this alveoli are going to be significantly elevated. Or in other words, you can make a calculation and say that if there is going to be an alveolus that drops to about 1/10 of its volume, the surrounding alveoli can have a major exaggeration of the stresses I mean, there's going to be a major exaggeration of stresses in the surrounding alveoli. Or if I was to apply a transpulmonary pressure of only about 30 centimeters of water, like we typically will do, this is going to translate into pressures of close to 135 centimeters of stress in these kinds of alveoli surrounding a collapsed structure. Or in other words, a non-uniform lung is going to have a dramatic increase in the local stresses. And this may be the reason why, even when it is functioning under normal stretch kind of conditions, there is likely to be very significant injury that is likely to occur under these conditions. So, in other words, this is the summary. The elastic properties, the stress and strain on the lung of the lung interstitium are central to the injury that occurs during mechanical ventilation. But the injury rarely occurs because the limits of elasticity are exceeded. On the other hand, the regional changes that can cause stress raises to develop are very important indicators of the development of lung injury. So with that as the background, I'll jump onto a completely different concept. Now, along this line, okay, this is a beautiful experiment in which they treated animals with a similar amount of strain. That is, they expanded the lung from a 0 value to a strain of roughly 2.5, which is close to the total lung capacity in this big model. Okay, so when they ventilated the lung, they ventilated it in different ways. In one situation, they kept the end expiratory pressure at 0, and the entire strain was created by a tidal volume that was very large. There was the other extreme where a very high amount of positive end expiratory pressure was given, and the strain was created by a very small additional tidal volume, okay, with varying levels in between. And what they saw was dramatic. When you caused a change in your tidal volume from 0 to a very high kind of a value, you created a greater amount of injury to the lung, in contrast to a situation in which the pressure was kept very high and only a small amount of strain was created. Okay, or in other words, a dynamic airway pressure that is very large was far more damaging to the lung than a static airway pressure that was raised up to a certain level. Okay, and in other words, a high amount of PEEP was much better tolerated than a high tidal volume that was being provided. And this is very important for us to understand, because this brings in a completely different concept. Up to this point in time, we looked at the lung physiologically as an elastic structure with elastin and collagen fibers, okay, that are causing a limitation in the amount of stress and strain that you can create. Now, in addition to that, it is important to recognize that besides the elastin and collagen fibers that you have, there is also a large amount of glycosaminoglycans and proteoglycans that are present in the interstices. And these are highly viscous compounds. And I think I need to understand the idea related to viscosity. Viscosity is a phenomenon that is very typically seen in liquid surfaces, where when you cause a deformity of the liquid, there is going to be a differential shift of the varying layers, or there is going to be a certain amount of resistance to the deformation. And as a consequence of this, there is going to be a certain amount of shear between the varying layers, and this will create a different kind of stress. Okay, so in other words, when you look at the viscosity, it is basically a deforming strain, okay, that under conditions, when you have a solid structure, this deforming strain will be proportional to the amount of stress that you will create. But in fluids, this deforming strain will cause a differential movement of the layers of the fluid and generate what is called an additional stress called the shear stress. And this shear stress, it is very important to recognize, is very clearly related to the viscosity of the fluid in between and the density of the fluid, but also has a very tight relationship with the rate of change of the strain. Okay, and this is quite important because very traditionally in an elastic structure, the amount of strain that you create is going to be only related to the total amount of stress that you create. and not the rate at which you change the stress. But in a viscous structure, the rate at which you change the stress is going to be an extremely important component. And viscosity will introduce a new a framework, or the framework of time, into the generation of this kind of injury. Okay, let me just put it back in a different model. Okay, and if you look at the elastic model, where I am creating a change in my strain, I am stretching my fiber by starting at a baseline value and then increasing my fiber length and then keeping it fixed at a specific length. And under those conditions, the stress that I will be creating will be directly proportional. At the initial phases, there is no stress. The stress will rise as the strain goes up, and then the stress will flatten as the strain doesn't continue to rise any further. And this will be the kind of linear relationships that you will typically see. So under these kinds of conditions, if I was to strain this lung faster by increasing the rate at which I'm causing a rise in my strain, it is not going to result in a greater amount of stress overall. Okay, the stress that I will be creating will be identical to the stress that I will be creating, even if I was to go at a lower rate. Or in an elastic model, the stress and strain are independent of the rate of change of the stress, or the stress that you're applying. Okay, this is again going to be completely in contrast to what happens with a viscous response. In a viscous fluid, okay, since there is going to be a stress between the varying layers, the faster you create the stress, the greater is going to be the shear stress that you're going to create. So in other words, the viscous fluid, the stress is going to occur during the process of the change in your strain. So if I was to apply a strain that is going to go up and then it's going to be sustained at a point, the viscous forces will be completely different. Under those conditions, the viscous stress is going to be something like this, where there is going to be a rise primarily related to the velocity of the change, and this is going to be sustained till that change is occurring. And then when you stop at that point in time, okay, it is going to remain constant. This is a completely different relationship from the stress-strain relationships that we saw earlier. And this is quite important, because if you change the velocity or the rate at which you create the strain, okay, you will create significant increases in the amount of stress. Now, this is a very important concept for us to understand, primarily because the lung is a viscoelastic structure. And as a consequence, the amount of stress that you create is not only related to the tidal volume and the pressure that we talked about, but is also clearly related to factors that will alter the rate of change of this tidal volume and pressure, which will include your respiratory rate, the flow, and for that matter, something like your IE ratios will all be extremely important in generating this change in stress. This is very clearly shown that the rate of strain is directly proportional to the amount of injury that you will create. Now, I will come back and summarize this very clearly. While we said a dynamic stress is more injurious than a static stress like PEEP, the viscoelastic nature of the lung matrix, okay, makes a tidal breath itself very harmful. Besides the restriction of your tidal volume and your airway pressures, a change in your respiratory rate and your flow velocity become extremely important in generating lung injury. Should I stop over here and just say, I can summarize this in a few words? Okay, look at the lung as an elastic structure. And if you look at the lung as an elastic structure, it makes a lot of sense that if you stretch that lung either excessively, large tidal volume, or you create a huge pressure within the lung, okay, you're likely to create a greater amount of injury, primarily because the energy that is being transmitted to the lung is going to be proportional to this kind of a change. But as we said, this is not adequate enough to explain it, primarily because if you just use this kind of a model, it will not explain why injury occurs at far lower values. The reason that it occurs at far lower values is the lung is heterogeneous, and because it is heterogeneous, it will create what are called regional stressors, and that regional stressors will act as a multiplicative kind of a factor for the amount of stress that you're going to be creating to the lung. Additionally, in those models, it looks like only the tidal volume and the airway pressure is important, and not the change of the rate of change of pressure. But we recognize that the lung is also viscous, and in a viscous structure, the rate of change becomes an extremely important component. And this is for the first time that we are recognizing it. Very typically, we will always say we can minimize lung injury by changing your tidal volume or keeping your airway pressures on a lower side. But we very rarely pay any kind of attention to the respiratory rate or the flow velocities that are being generated in this process. Now, this becomes quite important because this change in respiratory rate and flow velocity is a very strong component of the injury that you will be creating. Now, let me just express all of this in a little different way. So, if injury can be viewed as being proportional to the energy needed to move ventilatory gases, a larger tidal volume would imply that there is a greater strain. And if it is moved at a higher pressure, which means a greater amount of stress, it theoretically should cause a greater amount of injury. And this can be expressed in terms of the energy that is required, okay? That can be plotted by your pressure volume loop. The higher the pressure you generate and the larger the tidal volume you move, the greater the area under the curve would imply a greater amount of energy that is being transmitted to the lung, and that can be potentially harmful to the lung. And this can be simplistically looked at by your dynamic pressure volume loop on the ventilator. But there is another important component to this. When we are starting from a zero lung volume and then expanding it, this is all acceptable. But under most of our conditions, we usually start by providing a baseline condition where a certain amount of positive end expiratory pressure is given so that we can maintain the end expiratory lung volumes at a slightly higher kind of a value. And the addition of PEEP is also a certain amount of energy that is being transmitted. While this is a kinetic energy that is being generated on a breath-by-breath basis, the PEEP is a potential energy that is going to be transmitted to the lung. And that combination of both the PEEP and the kinetic energy is going to be expressed in your pressure volume loop, okay? And that will be directly proportional to the amount of injury that you will be creating. The larger the amount of the area that you create, either by a large tidal volume or by a higher pressure that you're going to generate, okay, it is going to be relevant. But it is also going to be relevant that you are adding a certain amount of PEEP. If you increase the PEEP, theoretically, you can be increasing the total amount of energy that you're transmitting to the lung, and that would be also dangerous. Up to this point in time, all of this is being expressed in terms of power, energy, okay, that is being transmitted to the lung. We are not expressing it in terms of the time relationships that are also important. As we said, in a viscoelastic structure, the frequency or the rate at which you cause the change in your airway pressures and tidal volumes is also equally important. And as a consequence, we need to look at this in a completely different kind of a way. So while we may calculate the energy for the potential for creating lung injury by using three components, that is, you look at what you call the elastic component, the resistive component, and the PEEP component, it is equally important to recognize that since it is a viscous structure, if you do this very frequently, this is going to create a greater amount of injury. And this is expressed usually in the form of what we call your mechanical power. Power, in other words, is effectively what you see per unit time. Power is the rate of energy transfer or the work or energy transfer per unit time that is very relevant. So if you have a very high respiratory rate, the amount of power that you will be creating will be significantly larger. And power is expressed as a function of all these areas. Effectively, the elastic component, the resistive component, and the PEEP component multiplied by the respiratory rate. And this becomes highly important for us to recognize that in the estimation of power, there is going to be a very strong component of the respiratory rate. In the past, we only have looked at the static components alone, but now we need to look at this additional component, which is the respiratory rate. You can calculate this by varying values, forget about this, but ultimately, we recognize that when we look at the mechanical power, which is to be plotted, we can look at it and see that the amount of mechanical power is directly related to every kind of adverse event. The hospital death increases as you increase the power. Okay, the ventilator free days actually will decrease as the power goes up. The length of hospital stay and the hospital duration of hospital stay and the length of ICU stay will all be adversely affected by the mechanical power. If they are all reduced, you're going to have a significant improvement in terms of all your outcome. This is very clear. So the lung injury that we're creating is a function of not only the pressure and volume changes, but the pressure and volume changes in unit time. And the pressure volume changes in unit time, or the work that is being performed in unit time is going to be expressed as a mechanical power. And this is probably a very important component. Now, do we know of a specific value at which the power can be adjusted? You can calculate the power, and many machines probably can give you this kinds of calculations because it is derived from traditional measurements in the lung. Okay. And we can always say, can we use that as a cutoff and say, if you exceed a certain amount of mechanical power, you're going to create injury. And if you're below a certain amount of mechanical power, you're less likely to create an injury. Like we have for, say, tidal volumes, for instance. Okay, say less than 8 cc's, less than 6 cc's would be ideal. Do we have similar cutoffs? If you really look at it, that doesn't seem to be there. In one set of data, the amount of power that identifies a potential for a difference in mortality seems to be at around 12 joules per minute. In another study, it looks like it is about 17 joules per minute, which is distinctly different. These two look very different. So we need to ask ourselves a question and say, if you can explain the lung injury nicely by the amount of power that you're administering to the lung, okay, why is it that we are not able to establish a specific threshold above which the power can be dangerous to a patient and below which it can be safe to a patient? And the reason for this is the fact that mechanical power alone cannot be a predictor of lung injury. Mechanical power is the power that is generated by the machine, and that has to interact with the patient's own lung. And the way in which that lung and the machine interact is going to be extremely relevant to the development of potential injury. And this can be easily simplified. So if I was to apply power to a lung that has a significantly elevated aerated lung, the yellow over here saying aerated lung and the blue being collapsed lung, in contrast to one in which there is far less aeration, when I transmit the power to a given power to this lung, it is going to result in less injury to this lung than it would be to the other lung. Or in other words, mechanical power has to interact with the extent of lung disease, and that will be the factor that will determine the amount of injury. And that is probably the reason why when you look at different studies, there is going to be different kind of thresholds for the amount of power that is going to create injury. This has been seen long time ago in a study in which patients were ventilated with 6 cc's per kg tidal volume, and they found about 1/3 of these patients have a significant amount of injury. And what is very clear is that 1/3 usually are the ones who have a smaller amount of aerated lung in general. If the amount of aerated lung is significantly larger, there is going to be less injury to the lung than you would see when the aerated lung is significantly smaller. Power is also going to be very important from the point of view of the heterogeneity of the lung. As we said, if a power is transmitted to a lung that is highly heterogeneous, the amount of injury that you can create, the stress raises, are going to be very significant. And as a consequence, it is quite important that we need to keep the lungs more or less uniform. And there are two processes that we traditionally employ. One is the use of the prone positioning, and the other is the use of positive end expiratory pressure. As far as prone positioning is concerned, we know that it significantly homogenizes the lung, and it is very clear that when you look at the power that is transmitted to the lung, power comes down quite dramatically, or in other words, the stress-strain relationships change quite dramatically in patients who are put prone and who will continue to remain that way once they have changed from a prone position back to supine. That is primarily because you're going to change the lung from a heterogeneous kind of a lung into a more or less uniform lung. And under those conditions, the stress-strain relationships definitely will show a lot of improvement. What about the application of PEEP? Now, when we said this earlier, we said if you apply PEEP, the total amount of energy that is transmitted to the lung is going to increase. So theoretically, if we believe that the application of PEEP is going to cause a greater amount of injury to the lung. But there is also another aspect that occurs is when we administer PEEP, we do see changes in the alveolar ventilation, and we do cause a lot of a reduction in the amount of heterogeneity that you see in the lung. And in fact, there is enough. When you apply a higher amount of PEEP in a lung that is recruitable, you actually will cause less of a driving pressure and probably an improvement in terms of the survival. And this is quite important, that PEEP has two ways in which you can look at it. As an absolute increase in power, it seems like it does, but it also seems to have a benefit within a certain kind of a level. So under these kinds of conditions, it is probably very important to recognize that when you are applying PEEP, it is not like a uniformly negative kind of an effect. There is a point at which the PEEP can be definitely beneficial without changing the power. This is the calculation of the lung power with the application of PEEP. At very low levels of PEEP, when you're converting a heterogeneous lung to a more homogeneous kind of a lung, you're unlikely to increase the amount of power. But when you increase it at much higher values, you're likely to create a significant change in the amount of power. Or in other words, PEEP has a dichotomous kind of a relationship. At the point at which it is recruiting the lung, it is going to be beneficial in terms of minimizing the amount of power that you're going to change. But when you have recruited the lung, the over application of PEEP is likely to create a greater amount of injury. Okay. This 16 centimeters of water seems to be an extrapolation from the animal studies, but it seems to be about what we will see. Very rarely with an application of PEEP much higher than that, we associate with improved outcome. Two other issues that we have in the calculation of power. Remember, when we're talking about power, we are talking about the power that is transmitted to the lung. And what we are usually measuring is power to the entire respiratory system, including the chest wall. And unless we have a esophageal balloon, we cannot be able to differentiate the power that is being transmitted to the lung. And there is always a question of whether we should be actually measuring the esophageal pressures under these conditions. Likewise, there is some concern that exhalation can also be a very strong concern, because during exhalation, there is a sudden shear stress because there is a sudden deflation of the lung. There is an abrupt change in the lung volumes that can create a huge amount of shear stress. And if retarding that can be of some value, we don't know. There is a process by which you can retard it, but we really don't know what the outcomes will be. So really, when we look at, does the application or the change in power cause a change in the mortality of the patients? This has been looked at in one retrospective study. And what they show you is that the total power, okay, has got no relationship with the mortality. Okay. And the same thing happens even if you use an esophageal balloon and look at the transpulmonary pressure power alone, it doesn't have any relationship. But what does have a relationship is if we can adjust the power to the area of ventilated lung, as I said, the point of interaction, or if you can adjust it to the compliance of the lung, okay, it seems to have a much better predictor. Or in other words, we cannot use mechanical power as a marker of a improvement or a worsening of lung injury. But on the other hand, if that is adjusted to the aerated lung volume and to the compliance of the lung, it may be far more relevant. So to come back to another summary over here, where we basically say tidal volume and airway pressure increases would imply that there is an increase in stress and strain. But as we said, these are by themselves inadequate descriptors. We need to include the concept of power, which includes a measurement of the time or the unit time, the change in energy per unit time that we need to be measuring. Additionally, we recognize that the regional heterogeneity of the lung and the extent of aeratable lung will also have to be accounted for. And maybe there is some value in transpulmonary pressures, but we are not very clear about that as it stands right now. I will go back through this and I'll give you some broad summary. Okay. Ultimately, how do we change the power? If we think power is potentially dangerous and we need to keep reducing the power, we have varying ways in which you can do it, but the interactions are very different. When you change your tidal volume, it is different from when you change your respiratory rate and when you change your PEEP. The change in your power seems to have different kind of relationships. And unless we do it on a practical basis and assess what is happening to the change in power, it is very difficult to know whether anything that we do will be beneficial or not. Okay, let me go back and summarize. Power is a descriptor of what the ventilator does in a patient who is being ventilated. Its contribution to acute lung injury is the ventilator's contribution. In addition to that, it has to interact with the regional pathology and the heterogeneity of the lung itself to create that injury. And this is the most important interaction, that power by itself is not a good indicator of the extent of injury or the potential for injury, but power in relationship to the underlying lung is going to be quite relevant. Okay, I'm going to leave it over here. I think I might have left a few points a little too confusing, but I'm very willing to have a discussion about these issues if you want me to talk about it. I have a bunch of questions that I will look through and see if I am able to understand it. Okay. Can I stop over here, Venkat Raman? Can I start answering the questions if I see any?
Yes, sir. I think we can stop, or you can take a few more minutes in if you have any conclusion. I think we can stop and take questions.
No, I'll stop and I'll look at the questions that have already been posted. Okay. And I will say, okay, how do you do? Let me just go. I think what
I'll take the question, sir. I'll take the questions to you.
Okay.
So
you do everything.
The question is, yeah. So the question is, we are talking about lung protective ventilation in many formats right now. We initially started with low tidal volume. Now we are talking about driving pressure, and not just only a PEEP. Now a mechanical power. So what are the things we will look at in?
Let me put this again in the context of this lecture. Let me explain what is lung protective ventilation. Lung protective ventilation is when you're going to cause a minimum amount of energy transfer to the lung to create deformation of the lung. Okay. This was initially thought to be very simple. We've started off with a low tidal volume and said it makes a lot of sense. Then we said, additionally, we need to look at the lower airway pressures. And ideally, this was seen by looking at your driving pressures, which is from your baseline to the maximum that you're changing. And that driving pressure is a good enough indicator. At that point in time, that is all that we thought, because we believed this was an elastic structure where the change in pressure and the change in volume are going to be the only factors that determine the change in the injury that you're going to be creating. Now, what we have recognized is, since the lung is a viscoelastic structure, it is not just the change in the tidal volume or the change in the airway pressure that is relevant, but the rate at which you create the change is going to be important. And this is done by calculating the power, which is the change in this, the amount of energy that you're looking at in a unit time. So it is the change in this that is going to be relevant. Or in other words, the respiratory rate becomes a very important concept. And along those lines, even issues related to the flow of airway, since the respiratory rate will determine the flow of gases, it will also become an important concept. So in the concept of power, we are not just looking at the elastic structure alone, but we are looking at the viscoelastic structure, which includes a time element. Okay, so if, for instance, I have somebody that I'm ventilating at a rate of 16, okay, I will have a power that is going to be less than if I am ventilating the same patient at a rate of 20. Okay, and it is quite important because I am now ventilating at a faster rate, and I'm likely to be creating faster flows to this patient. And as a consequence, I will be creating more damage. So when I'm talking about lung protective ventilation, it is looking at all of these components. Now, we thought it was very easy. Now that we are doing all of this, we said, let's just calculate the power and say that that power value will be the best way in which, if I keep it to a minimum, it will be great. But what we are recognizing is that power is good. The lowest amount of power is good purely from the ventilator standpoint. But how that power interacts with the lung is equally important, because the lung is a very heterogeneous structure. In patients with ARDS, you can have lungs that can be very severely affected, and very small tidal volumes may be possible. Other lungs which may be quite widely open. So when you're applying a external pressure on that lung, the amount of interactive surface is going to be very important. If there's a very large interactive surface for a given unit of power, it is going to be less injurious than if the same power is going to be transmitted to a much smaller lung area. And that is the second component that we're looking at. So unfortunately, as we understand it more, we're finding it less easy to draw a line and say, this is what we need to do. So how will I perform lung protective ventilation? I'll start with the simple rules. I'll start with that 6 cc's per kg kind of tidal volume. Okay, I will look at my airway pressures, and we find that a plateau pressure, a driving pressure of close to 15 or lower is potentially less injurious than anything else. Once I've achieved that, if I can calculate the power, I will calculate the power, but I will also focus a little bit on my respiratory rate. In the past, we used to say, if the patient has a PCO2 that is rising, just increase their rate. I would be very careful about that. Okay, but I don't have a hard and fast value to say, if it reaches such a power, I'm going to stop it. No, but if I'm able to achieve reasonable blood gases with a low respiratory rate and a lower flow rate, I'll be extremely happy. Okay, so that is the way.
So you're giving towards a hint that lower rate, more inspiratory time, lesser the flow, your injury may also have a complexity. That means we are adding respiratory rate, inspiratory time, and flow.
Ultimately, we are doing that. All of that is being interactive. And if you look at the calculations on power, you'll notice that all of those factors will be included in that. Okay, the formulas that I was showing you there, all these factors will be included in that.
So many of us who have been following this ARSNet protocols guidelines of giving a respiratory rate up to 35, IE ratio between 1:3 to 1:2 to 1:1.5, 1:1 inverse ratio. Can you give us insight of, can we play around that to drop the mechanical power?
See, again, when we were doing the ARSNet kind of a protocol, we were going with a low enough tidal volume. Okay, and the direct association of that low tidal volume has been an elevation in your PCO2 and the fact that you're developing a hypercarbic kind of a state. Very typically, we are told to respond to that hypercarbia, particularly if it is also marginally more acidotic, by increasing your respiratory rate. This was done at a time when the concept related to lung injury was not very clear. At that point in time, we only believed that the most important thing was keeping the tidal volume low enough. Okay, and that if it resulted in some kind of hypercarbia or a respiratory acidosis, we need to try and compensate for that by increasing our respiratory rate. To me, I think that that is not necessarily a very acceptable kind of an endpoint. The question is, where will you draw your threshold? That is going to be very difficult. Would you be very comfortable letting a pH drop to less than 7.0? Most of us probably will worry about the other component also. Okay, this is beyond the power and the direct lung injury that you're talking about. This is a worsening of the other physiological parameters. So, but in general, what this has done is, when I see a rising CO2, I am much more tolerant of a permissive hypercapnia under these circumstances than I used to be, primarily because I also understand that raising the respiratory rate and raising the flow under those conditions would not be the best thing to do. Okay, keeping your IE ratio as 1:, closer to 1:1 or 1.2:1 if you want to keep it. Okay, not inverse ratio, but as close to 1 as is possible, is completely appropriate because it will also translate into lower flow rates. And those lower flow rates are also potentially likely to create less of a transmission of power and less of a lung injury. Okay, so this is what it has done to me. I have not jumped into this power business and say, I have decided that this is the power I'm going to keep this lung at. I have not used that. But I've used the concepts related to power and the viscous injury to regulate my respiratory rate to more conservative values than I used to. In the past, we'll always ventilate 24, 28. We'll be very comfortable about it, okay, because the pH will come back towards normal. But right now, I have a tendency to say keep a much lower rate if it is possible.
So there are some interesting questions. You spoke about aerated, non-aerated lung, which will give you some guess of your relevant mechanical power, which can be harmful, which cannot be harmful or cut off. You said one study said 12, other study said 16. So you said it depends on how much is the aerated lung component, which will give you the idea. So the question is, how do you correlate that? And how do you decide onto a mechanical power?
No, that is the whole problem. Okay, that is the whole problem. What these studies are showing you is that with the variation in the amount of aerated lung, okay, there is definitely, if you try to correlate the power with the outcome, it doesn't correlate very well. But if you adjust the amount of power to the amount of aerated lung, it correlates better. Okay, but I don't know of a practical way in which I can measure the aerated lung. Most of us don't have access to a a good quality CT at the bedside or otherwise.
Yes.
Okay, you're not going to be able to do it in terms of being able to estimate the amount of aerated lung, which is why it makes it that much more difficult. Okay, that I would like to put down as a very clear limitation to the idea of power. When you have a power, you can't use a specific value, primarily because it is so much the interaction with the aerated lung that matters. Okay, a far more practical kind of a method would be to say, if I can look at it in terms of my lung compliance also. So if my lung is very non-compliant, then I probably would like to use far less power as my
lower
cutoff.
power.
Yeah, you have to use far less power than under other circumstances.
Maybe the need of driving pressure, the need of, as you said, the compliance, both can be linked. As one of the studies said, your compliance when linked with mechanical power, they could show a little benefit in
better,
that.
yeah, they show a better correlation with survivalship. Okay, but it doesn't give you cutoff points. Please understand, it doesn't tell you this is good and this is bad.
I think that will continue because, as you said, it will vary from one lung to other. So giving a cutoff will not be future also.
Yeah, I think basically what we need to recognize is the lowest amount of power that you can deliver in a given patient is ideal. We can't put a limit basically and say, I have to aim for a specific target. You look at a target, see if you're achieving your tidal volumes, I mean, your stabilization of the patient. And if you're able to reduce your power further, you're probably doing them good. There is no clear lower limit to this also. I think the same is also true of driving pressures. We all get
exactly.
We always say, oh, 15 of driving pressure is good. But actually,
12 will be
if
better.
you can achieve even lower values, it will be even better. But that will have to be looked at in terms of the overall picture of the patient, the stability, the acidosis, oxygenation, everything else becomes very relevant. So that is exactly the way in which we need to look at it.
And we also see, we also see along with compliance, when we see a lower driving pressure needed to deliver the same kind of tidal volume or oxygenation targets, we see a recovering lung, and that also reflects
Absolutely. There again, there'll be a little bit of a problem. Whenever we're looking at compliance in a patient like this, just be very careful that if the patient is not sedated and paralyzed, And if they are on a pressure control kind of a mode, your estimation of compliance on the basis of
Maybe
the plateau
erroneous.
pressure there will be completely erroneous, primarily because the patient's esophageal pressures are not being measured, and it is likely that it may be far different from what you're estimating over there. So
And
these are
another
all practical. Yeah, go ahead.
a question linked to that, sir. He is asynchrony of the patient. When a patient fights with ventilators, will do affect a mechanical power worsening it.
I don't see it. Asynchrony will cause, well, definitely breath by breath changes in terms of the amount of work that you will be creating. How it will affect your power, I can't predict exactly what the direction will be because you don't know what the extent of asynchrony will be. So, but asynchrony theoretically can be something that will increase the amount of power that you probably are.
So there is another interesting question related to the self-inflicting lung injury when a patient tries to breathe harder and with a higher tidal volume. And that head-on comparison with what we are now talking about, a mechanical power.
No, I'm not able to understand what you're saying.
So there's a question related to self-inflicting lung injuries, which we see a patient who is breathing spontaneously, taking a larger tidal volume and a higher rate.
Yeah, we talked about it in all our COVID patients.
COVID patients.
Yeah.
Those who are on spontaneous ventilation on NIV or.
Yeah. So effectively, there the amount of work. See, ultimately it's the same thing, right? Whether it is machine delivered or whether it is spontaneously induced increase in the amount of work that you're going to be generating, the greater the amount of injury that you're going to be potentially creating. So under pathological conditions where you need to be breathing very hard, you theoretically can be also increasing the amount of power that is being transmitted to the lung. Okay. And this again, because it is going to be requiring a measurement of your esophageal pressures and your transpulmonary pressure, because an airway pressure alone will not be an adequate reflection of what the spontaneous breathing is going to do. Okay. It'll have to be estimated in different ways. Much of the work related to power has been in patients who are sedated and paralyzed, okay, and mechanically ventilated under those conditions. So the issues of asynchrony and spontaneous breathing, all of that will be a bit more difficult to introduce. In right?
So you say the power has to be linked, or protective ventilation has to be linked with low tidal volumes, driving pressures, respiratory rate, flow, and probably the lung, aerated lung. So if I have to select sequentially, one of the participant is asking, how will I sequentially prioritize them? This is the first priority, next. We know sometimes it is ideal situations are not always possible.
Yeah, I put it down very, very clearly in the last graph that was representing that the way in which the relationship between the power and say respiratory rate is not the same as the relationship between power and the change in PEEP. For an equivalent amount, say a 20% reduction in respiratory rate, will I have the same amount of reduction in power as the 20% reduction in PEEP? And the answer to that is no. Also, we have to remember that when I make these changes in one parameter, it is very likely that I will alter these other parameters also simultaneously. So when I'm making any kind of a move, okay, while I understand respiratory rate is important, the easiest way in which I can reduce the power is to reduce my respiratory rate. But by reducing my respiratory rate, for instance, I can cause a lot of changes in the compliance of the lung. I can cause changes in the airflow. Everything else can also affect it, and that can also change the power. So ultimately, unless I'm able to see what is the effective change in power, it is going to be very difficult to make a judgment of which is the best maneuver that you can use. That is what I was implying in the last one. In fact, my last slide says, how do you manipulate the power? I'm not very sure. Okay. I don't know which will be given a priority, but all of them will need to be given a priority. To me, the highest priority will always be the respiratory rate, because that is going to be a very big magnifier of the amount of energy that you're going to be transferring to the lung. And very clearly, the one thing that we have learned from this entire process is the focus on tidal volume and airway pressures, whether it's driving pressure or not, is not adequate for you to minimize the lung injury. that additionally, a focus on respiratory rate and flows are also equally important. Trying to keep them as low as is possible is going to be extremely important if you want to minimize that injury too.
So there are questions related to, do we get this mechanical power on the modern recent ventilators like compliance
I
and
don't know. I don't know which machine does it, but it's very easy for them to fit it in. I'm pretty certain there must be a couple of machines. I've not looked at any recent machines myself.
So right
but
now,
it's
right now we calculate.
No, but right now it's possible to calculate it and even get a dynamic kind of estimate on a machine. I'm pretty certain that somebody will be already working on it. Okay, I'm not very sure. If someone can find it out, you can look at it. But basically, but I would be very worried about it. Okay, if some machine generates a power value and gives you a power value,
yes,
would I
misuse.
use that? Yeah, it'll have a big tendency to say, I want to reduce my power. I want to reduce my power. I'll do whatever I can to reduce my power, which may not be the right thing to do. Okay, we don't have any data on that at all. Okay, while all of these are retrospective data that shows you a correlation between power and bad outcome, there has been no data to demonstrate that a manipulation of the power results in an improved outcome. We don't have a randomized control trial of saying aim for a power of 14 joules or aim for a power of 18 joules and see what the difference is. We don't have that kind of data yet. We don't even know. Will it be actually manipulatable? I don't even know. If the underlying lung is what is going to be very important, like I said, it is not the power that matters, it's the power's interaction with the underlying lung that matters. It is also very important to recognize that the healing of the lung, the improvement of the lung is going to be as relevant to improving outcomes as the change in power. So it's very likely that manipulations of power may not translate into any kind of a big benefit. Okay, but it gives you some kind of an indication about the fact that you are transmitting a very excess amount of energy that can potentially hurt the lung. So trying to keep it down to a minimum would be a reasonably logical kind of an approach.
The questions related to, can we calculate the power in all the modes, including dual and ASV modes, or we need to have a volume targeted ventilation mode to calculate the power?
No, I quickly showed it in that graph. They were both calculations that are derived on pressure and volume targeted modes. Okay, they'll have to be minor modifications of the broad idea. It can be done.
Dr. Sasidhar asking a very interesting question. Now we are talking about a protective lung ventilation, adding one more component to that. Are we pushing towards a more lower threshold of ECMO in ARDS patients, saying we are crossing limits?
It is absolutely fascinating. Okay, there is a risk benefit that we need to look at in terms of the ECMO use, right? Logically, if this is very true, and reduction of respiratory rates and tidal volumes to very low levels are going to be ideal, extracorporeal circulation would be the best way in which you can achieve such a low rate and a low tidal volume. Okay, so that becomes logical. But the fact of the matter is, extracorporeal circulation doesn't come at a zero risk. There is a certain amount of risk that is involved in the placement of extracorporeal support. And we need to look at the risk-benefit balance. While physiologically, it seems like completely resting the lung will be the best way in which you can minimize the injury to the lung. Okay, we have to draw a threshold and say, this is the point at which we will have a benefit, beyond which, we probably need to consider an alternative. In fact, I would almost argue that the thresholds for initiating ECMO should not be based on our current kind of parameters, but probably on issues related to power. If you can demonstrate that you are not able to reduce your power adequately, okay, on a given patient, should you be switching them over to ECMO a little earlier? We don't
exactly.
know.
Exactly. He's trying to put that question in that way. Yes, we don't know what is the.
Yeah, it seems logical. But again, please be very careful, because ECMO is not like a therapy with zero adverse effects.
Risk.
Zero risk, basically. It is a risky kind of a procedure. And any kind of benefit that you will get will be marginally affected by that adversity also.
There's
I think we need to
another
look at that.
interesting question from Sunil saying, dropping flows and respiratory rate and probably optimizing PEEP, you may increase the CO2 as you said. What will be your CO2 cutoff for a pH cutoff in these situations, and how frequently you need to monitor the ABG?
Yeah, see, obviously you do need to monitor the ABG frequently enough if you're going to have such a kind of a situation. Where is your cutoff level? I don't know. Again, I don't know. But many people would say a pH less than 7.2, along with a PCO2 that is sufficiently rising, would be something that they will be very scared about. But if the patient is relatively hemodynamically stable, it is unlikely to have any adverse effects from the increasing acidosis, we can be quite liberal about the reduction even further. Okay, so I don't have any cutoff. This is again coming back to the old idea of what level of permissive hypercapnia will you tolerate. Okay, I don't know. Okay, I have a tendency to tolerate permissive hypercapnia to much higher levels in stabler patients than I would in an unstable patient. If the patient is also having serious hemodynamic compromise, I probably won't have the courage to, let my pH drift down to less than 7.2 or less than 7.0. Okay, 7.2 is very comfortable for me.
Babu sir has a comment on board, sir. He said, excellent talk, but re-emphasis on the current evidence on low tidal volume, low driving pressure, recruitment by proning before respiratory rate and flow. Is it a way to go?
Yeah, I still would. Is he saying that we need to continue to emphasize the low tidal volume, the low
low driving pressure, and he's saying is low tidal volume, low driving pressure, and recruitment by proning before the titration to the respiratory rate and flows.
Yeah, I don't know whether. Yeah, I could probably agree with him. I would also agree with him that the more traditional processes which are associated with an improvement in outcome, all three of them have been shown. Low tidal volume reduces mortality.
Right now, that's what we are
proning. Yeah.
Right now, that's what we are doing.
All that is acceptable. Yeah. I don't know how much more this is going to change. It is only giving us a better explanation for the process, and it's probably also giving us a better understanding of the conceptual importance of the interaction between the lung and the ventilator that is relevant. Okay, I don't know how much it will change our ventilatory strategies. Right now, I would agree with Babu that I would do exactly the same.
But I think, sir, you added a point above that is right now when we actually look at the bedside situations, the respiratory rate remain to be a unprioritized component among the ARDS population. I see patients whose PF ratios is good. My O2 is somewhere in 45, 50, but rate still remains in 30s, 28s. So one of the component is we can reconsider dropping the rate and see whether I can still.
Absolutely.
So that's an addition.
Yeah, that's all I'm saying. So all this is, it's a conceptual change that is going to be brought in. And okay, I would have a tendency. I walk in my ICU and if I see somebody being ventilated at 28 breaths a minute, I just look at my gases. If it looks reasonable, I'll say, cut it, cut the rate. Will it translate into anything better? Yeah, hopefully it will.
Hopefully
okay. So we don't have any hard evidence about it. But see, I think it does make us understand the idea a little bit better. I think recognizing that is probably very relevant.
Sonia asks whether we can calculate the mechanical power by manually or using some software in your cell phone right now. Of
course you can. Manually you can calculate. I don't know, one of the slides that I had a reference to Gattinoni's papers basically on a simple method of calculating all of this. It is possible to do it, yes, with the routine parameters itself.
Some specific questions related to the periodic suction in a closed system. Will it have any role to play in preventing willy by dropping?
Periodic suction, I don't know. Okay, I'm not very clear.
I think we covered most of the things in the question box. The other questions repeated and there's nothing more specific. I think we had an excellent session of learning for all of us, including we. There is another question added, how to know stress index by looking at the pressure time graph? Is it a value normal or abnormal?
Okay, no. Stress index is completely unrelated to the stresses that I was talking over here. Stress index is basically the slope of your pressure time curve effectively, right?
Yeah.
And that is completely independent and not relevant to the current talk at all.
Okay, so that's it. And thank you, sir. It's always a pleasure. And there were more than.
Could
Yes,
I
sir.
take a minute? I
Yeah.
have to apologize. I don't think, as I was going through the talk myself, I thought I was being a little vague in many kind of places. But I think the subsequent discussion seems to imply that at least some people have got the concepts clear and have the ideas that I needed to convey. If there is one thing that I conveyed, is you can't just look at the amount of energy or work that is being transmitted to the lung and say that is equivalent to the lung injury that you will create. But you have to look at it also as a function of time. And that is important. If we can get that idea into our head and say, anytime we give 30 breaths in 1 minute instead of 20 breaths in 1 minute, we are potentially hurting the patient with a larger kind of rate. If that is the one idea that goes through the head, it'll be worthwhile. The rest of it is at best theoretical at the current time. Okay. And we need to understand that it's not going to be a solution. It's not like power is going to answer all our problems. Power is going to be a problematic thing because we need to look at it in terms of the interactions that you have with the underlying pathology. And that is going to be the biggest problem that we will ultimately have to solve. So if somebody asks me, how can I, yeah, go ahead. Sorry.
No, so please go ahead. I think that has been clear and I think from the interaction, what we can understand is everyone has got into that point that they are looking at.
Okay. So I think that will be the point that we would have raised. I would be happy with. Okay.
At this point of time, we still have many things unanswered, as you pointed out. What will be the limit? How do we know the aerated and unaerated lung? What will be the ideal cutoff? Is that implies to any outcome benefit? Do we need to combine compliance? Do we need to combine driving pressure to that? All that needs to be still unanswered at this point of time. But keeping an eye on that, and a patient where I have an option of dropping the flows, dropping the respiratory rate, and dropping the mechanical power is as good as dropping the driving pressure and having a more safer ventilation than I was doing before.
Yeah, I completely agree. And just to give you a historical kind of a view, when I started ventilating my patients in the late 1980s, okay, the way in which we were creating damage to the lungs was something that I wish I never had done. Okay, right now we clearly are ventilating much better. And any kind of improvement beyond this stage is going to be very imperceptible to us, at least. It's going to be so marginal that it's going to be very difficult for us to say that we are really making a big difference. But ultimately, I think all these small changes do translate into bigger outcomes. And I hope that I was able to get that idea in. Okay, I'll leave it at that.
Absolutely.
Okay,
yes, absolutely, sir. Thank you, sir. Thank you being with us. And
Thank you.
It's always a pleasure. And all of us, all the participants enjoyed the topic thoroughly. We can see that interactions, many more questions topping up till. We thank you for being with us and giving your valuable time, sir. I conclude the session, thanking all the participants, sir.
Thank you very much. Thanks.